Dr. Faubion serves on the HHSC Dangerousness Review Board, is the chairperson of the Forensics Committee or the Forensic Services Committee, and participates in the Joint Committee on Access and Forensic Services. Welcome, Dr. Faubion.
Thank you, and it's a pleasure to be here today. I was particularly gratified to see so many friendly faces in the audience because over the past 10 years I've had the opportunity to work with many of you in different capacities. And what I'd like to do today is to talk with you a little bit about the practice of forensic mental health care in the state hospital system, since so many of you in the audience are involved with individuals who are sent to the state hospitals under forensic commitments. I wanted to use this opportunity to tell you what we do in service of those individuals that you send to us, and by extension, service to your organizations. Now, this worked until folks were in their seats waiting, let's see, like magic. Okay, so what we're going to talk about today is the forensic patient in Texas. What does a forensic mental health patient look like from an inpatient standpoint? Secondly, we'll talk about that pre-admission clinical review that Professor Shannon spoke about, the 562 review. Then I want to talk a little bit about Dangerousness Review Board within the state hospital system and what that means, because it's slightly different. Then I'll talk a little about state hospital settings and service availability across the system, and then I want to talk with you about some new directions in forensic care. So what does the forensic patient in Texas look like? They're predominantly male. The forensic mental health system looks more like the correctional system. So in a private psychiatric facility that is non-forensic in nature, most of the patients would be women. But in the forensic mental health system in Texas, it's predominantly male. 80% of those individuals have a primary psychotic disorder. And by that I mean a difficulty distinguishing what is real from what is not. And they're typically, those individuals are refractory to initial treatments. Now, of those forensic mental health patients, at least 3/4 have comorbid substance abuse. Because as we know, individuals who are committed to the state hospital under forensic commitments are often committed as either not guilty by reason of insanity for violent offenses, or are charged with violent offenses but are incompetent to stand trial. Substance use and violence has a tremendous overlap, and that's a subject for a different talk, but the overlap and the comorbid substance use in this population should be of no surprise to people in this audience. They're primarily felony defendants or individuals acquitted by reason of insanity for felony charges. Now, that being said, there are about 220 misdemeanants occupying state hospital beds for competency restoration. And I am aware of the due process needs of the misdemeanor defendant, but one of the decisions that we have to make as a state moving forward is how do we use limited resources? And at other points in this meeting, you'll hear about diversion for misdemeanants. And I think that that's critically important as we free up limited bed space, potentially, for alternate uses. Most of the individuals in the state hospital system under forensic commitments are committed as not competent to stand trial. In fact, about 95% of those patients are committed under Article 46B. And later in this presentation, I want to talk with you a little bit about what that assessment process looks like and what the inpatient restoration processes look like for those individuals who are sent to the state hospital system under Article 46B. Now, forensic patients stay longer in the state hospital system than do civilly committed patients. In fact, you can treat about 7 civilly committed patients for every 1 forensic patient in the state hospital system. And we'll talk a little bit about what that means for access to care. We have 2,269 inpatient beds in the state hospital system. The occupancy rate is in excess of 94.5%. We are using the beds that taxpayers fund. And of those, about 2/3 of the beds are occupied by individuals on forensic commitments. And I've got some graphs that will illustrate this later on for those of you that are more visual. And I think that the graphs are helpful in pointing out some areas of emphasis moving forward. Of those forensic patients, 80% are on competency commitments. The remaining 20% are acquitted by reason of insanity and sent to the state hospital system, where they stay even longer than their 46B counterparts. And we'll talk about what that means later on. Now, in fiscal year 2016, the system experienced a forensic crossover, meaning that in fiscal year 2016, there became more forensic patients in the state hospital system than there were civil patients in the state hospital system. And I want to talk with you a little bit about what that means for care moving forward. So what's the timeline of patient movement through the state hospital system? Typically, it's a felony arrest. There's a finding of incompetency from an evaluator. Then there's a clinically informed determination of site of admission, that 562 review. Then competency restoration or treatment aimed at community reintegration and transition for those NGRI equities. For those that are incompetent to stand trial and restored, then there is a trial and adjudication and a found NGRI out of those proceedings. Those individuals come back to the state hospital system if there's a finding of dangerous conduct associated with that insanity acquittal. So that's the overview of how folks move through the system. So what does 562 review look like? So I've chosen to call this clinical review for placement of forensically committed persons. And what this is that determination by HHSC of the most clinically appropriate site of forensic commitment. Now, this is new legislation that was effective on the 1st of September of this year, and in the past, charge type dictated where individuals went. So for instance, if you were either acquitted by reason of insanity or found not competent to stand trial for a set of violent offenses, then you had to go to maximum security. And those facilities are at Vernon, Rusk, and soon at Kerrville State Hospital. So what changed is now courts commit individuals to care of HHSC, and then their clinical situation is examined to determine the most appropriate setting for care, with an eye toward risk management, community safety, and the individual's treatment needs. Now, this is a 3-tiered review process, okay? And I want to talk a little bit about what that looks like as we place individuals that you commit to us. First and foremost, the basic system remains the same. The way that HHSC has operationalized this legislative change is that individuals charged with violent offenses are in an MSU, maximum security, track. Furthermore, individuals charged with or acquitted of nonviolent offenses that would not have required MSU care are now in a non-MSU track. So things stay the same unless we waive individuals out of MSU or waive individuals into MSU from a non-MSU setting. So things are the same unless we apply a waiver, and I want to talk about what that waiver looks like, because as you send us information, the more that you send us, the better the finding, the more complete the finding. So some of the things that we're looking at is an individual out on bond. In the past, prior to 1 September, it was completely feasible for an individual to be on bond in the community and have to go directly to maximum security. So an individual may leave their job with the city of Houston on a Wednesday and report to MSU on Thursday morning. That's a likely and inappropriate use of very limited maximum security beds. So bond status is a consideration. If folks are okay in the community, then they may not need maximum security. Also, we look at successful prior treatment in less restrictive settings. Have folks done okay outside of maximum security in the past? Looking primarily not only at treatment response, but community safety and risk of unauthorized departure. Also, we'll look at the details of the offense. That's important to me. Who was the offense directed against? What are the circumstances around that? Were substances involved? What were the details that may make that individual appropriate for care in a more structured, more secure setting? What is in their clinical best interest? Now, all these reviews are done with an eye toward a risk of unauthorized departure. If we've decided that an individual can benefit from less restrictive settings, then we need to make sure they stay in that less restrictive setting. So if an individual has a history, for instance, of evading arrest or leaving facilities that are less restrictive in nature, then they would be started in a maximum security setting. Violence and community safety, so risk of violence and community safety. That is of paramount concern. While individuals need to be held in the least restrictive yet still clinically appropriate setting, I'm acutely aware of the fact that forensic patients are often forensic patients because of risk to others in the context of a mental illness. So community safety and violence risk factors are weighed carefully. So let me talk about that three-layer review now. I told you it was a three-tiered review. So a clinician will provide an initial screen of each packet that your jurisdictions send to HHSC. So for individuals awaiting admission to maximum security, that is Vernon or Rusk, that packet comes to Austin. For individuals that are, for instance, awaiting admission to San Antonio State Hospital, Big Spring State Hospital, a non-maximum security setting, then that packet would go to that respective facility. But there will be a first layer review, either centrally in Austin for those individuals in the MSU track, or at the less restrictive facility for individuals in the non-MSU track. And based on that first layer review, information is forwarded to me. So for instance, if an individual at San Antonio State Hospital, their clinical screener, has concerns about the information in a packet and believes that the individual may not be appropriate for the less restrictive setting at San Antonio State Hospital, then that information is forwarded to me for review. Furthermore, if individuals in a maximum security track are felt to not need maximum security level care, then that information is forwarded to me for that second layer of review. Then if I agree with that waiver, then I'll endorse that and send that to the Associate Commissioner of the State Hospital section for final review approval. So that's the multi-layer review. Now, after that process is done, and this is done prior to admission, so when someone is entered onto the waiting list, either maximum security or non-maximum security, that information is reviewed. Now, I'm aware that mental illness is dynamic and things can change, and if things change, then it's incumbent upon oftentimes your detention center staff or your medical staff to inform us of that. But the court is notified of the location of admission when this review is done. Not only will your court be notified of where this individual is being admitted, but also who the point of contact is at that facility should you have questions. So my hope is that streamlines communication, because I think one of the things that the state hospital system can improve on is communication with the courts. I think that we've not done as well with that as we should. And it shouldn't be a black box when your patients come into the state hospital system from your courts. Now, I'd like to distinguish this idea of the 562 pre-admission review for appropriateness of clinical setting, that is either MSU or non-MSU, with what goes on in the Dangerousness Review Board. Now, there is a term, and that term is manifestly dangerous, and I could read the slide to you, but you can read it yourself quicker than I can read it to you. And this is not a clinical term. This is a statutory creation applied to individuals who require maximum security level of psychiatric care. So when individuals go to a maximum security unit, they are subject to review by this Dangerousness Review Board. And that first review is within the first 45 days after admission, and then no less than every 6 months thereafter. Now, treatment teams can bring people before the board sooner than that every 6-month review. If they believe that someone has improved to the point where they are no longer manifestly dangerous, an individual can be presented monthly. But the board is held for either 2 or 3 days a month by video teleconference. It's a 5-member board, and that board, which I've chaired the majority of the time for the last 10 years, is concerned with who is appropriate for transition out of maximum security. And this is what the board looks like. These are the member qualifications to sit on the State Hospital Dangerousness Review Board, tasked not with making pre-admission decisions, but instead making decisions about transition through the system from a maximum security to non-maximum security setting. And the way that this works, and some of you may have seen these proceedings, the treatment team submits a report, and that written report is reviewed by board members prior to that monthly board. Then the treatment team makes an oral presentation. The patient being presented can call witnesses, can testify on their own behalf, and then board members will ask questions aimed toward determining whether the individual requires maximum security level care or not. And in order for an individual who's in a maximum security unit to move to a non-maximum security unit, all 5 members of the board must agree that the individual is not manifestly dangerous. So if one person out of that 5 believes that the individual still requires MSU level care, then the individual stays in maximum security. On average, this board hears between 40 and 60 persons over those 2 to 3 day period. And the pass rate, that is, individuals found not manifestly dangerous who move out of MSU settings, is somewhere between 35 and 45%. Okay, to give you an idea about the numbers. Where do they go? They go to these receiving hospitals after they may pass the Dangerousness Review Board, and what do they get there? Well, state hospitals provide the most comprehensive array of psychiatric services available to any psychiatric inpatient in the state of Texas. I can say that because on the weekends I work in a private psychiatric facility. State hospitals provide unparalleled medical and psychiatric care in the state, and it's expensive. But amongst those services are competency restoration, specific programming for certain populations, perhaps geriatric populations, neurocognitive disorders are addressed specifically on certain units in the state hospital. Multicultural issues are addressed in specialized units in the state hospital system. Psychiatric and psychological services are provided, rehabilitation is provided, social work and transition services are provided, and folks receive the very best medical care in their life. I'm not here to read the law to you, that's your area of expertise, but I want to talk a little about competency cases for a second. And this is why. This is a breakdown of state hospital census as of the end of the last fiscal year. So we're looking at around 1 September. And the reason I chose that is because that's the start time for our 562 review. And the orange line is length of stay. How many days do these particular patient classes stay in the state hospital system? And the blue number are the numbers of individuals in that commitment type. So on this slide, there are 262 NGRI equities in the state hospital system as of 1 September, with an average length of stay of 693 days. Okay? Now, the idea is perhaps there are individuals with certain clinical characteristics that stay a long time too. Geriatric patients, that is older patients, typically with dementia and medical needs, stay 580 days. And the largest patient group on this slide are those incompetent to stand trial of 877 persons with an average length of stay of 190 days. Now, there are more beds coming online. But in the interest of transparency, I want to show you what's happened to state hospital admissions over the last 12 years. They've gone down significantly, primarily with respect to civil admissions. And for those of you that work in local mental health authorities, you know this. And forensic admissions, that's the orange line at the bottom, has stayed fairly consistent. So it's not that forensic patient referrals or admissions have gone up dramatically. It's that they stay longer. And over time, they've filled the system based on differential length of stay. And then in the graph, which is on your right, I simply teased out the declining numbers of state hospital admissions. Now, More beds are coming online, but rather than wait on new beds, we've enacted a series of initiatives aimed at efficiency in the system to better utilize the resources that we have. And targeting that largest patient group, those incompetent to stand trial, I've illustrated on this slide. The blue line at the top are the numbers of individuals discharged from the state hospital system on 46B commitments. The orange bars are the length of stay. And what I want to show you here is that with a length of stay increase of 16 days from fiscal year 18 to 19, we served almost 200 less patients on 46B. So I would submit to this group that if the state hospitals can be more efficient in their operations and turn beds over more rapidly, we can serve more people. Now, you're going to ask me, how do we do that? And I'll tell you. Now, outpatient competency restoration and non-hospital-based modalities will be talked about later on, so I'm going to skip through this and talk with you about what inpatient competency restoration looks like. Now, 70 to 80% of those individuals that you find not competent to stand trial will restore to competency within 6 months. That's national literature. And the treatment modality is most often antipsychotic medications. The individual can't tell what's real from what's not. When they're treated, they know what a judge does. Now, involuntary medication for competency restoration plays a role, but if we can get meds to people, that is far more important than what programming we offer. So what have we done differently? I've told you that we need to use our resources better. We are now screening for trial competency every time that the recovery plan is reviewed. Now, as Professor Shannon pointed out, restoration of trial competency is not the same as treating an individual's mental illness for discharge from the hospital. But now, with this clinical competency screen to be done every time a person's treatment plan is reviewed, we're keeping this idea of trial competency at the front of the mind of our clinicians, with the hope that we can refer people more quickly than maybe we have in the past. This is a standardized screening form. It's yes, no. It's not been normed. It's not been subject to peer review. It is there to prompt treatment teams about forensic issues. Because what's happened to a lot of our recovery teams is they've become forensic clinicians whether they wanted to or not, because of the transition in the system. So by better arming them to provide these reviews, my hope is they will be more efficient. Now, on the 4th of September 2019, we had a state hospital-based training session for forensic evaluators. So everybody within the state hospital system who provides forensic evaluations attended this training, and it was taught in concert with our academic partners at Sam Houston State University and their forensic psychology training program, as well as the Capacity for Justice and Dr. C. But on this evaluator training, we established minimum standards for competency evaluations. We also used this training to establish those individuals who may constitute a registry of qualified forensic examiners for the state hospital system, and a group that we can subject to peer review. Because one of the things that I want to offer you as our primary consumer is that individuals who come to us receive state-of-the-art treatment, and you get back a work product that you can understand and that is usable for you. So by subjecting state hospital evaluators to peer review, I can ensure that you get a quality product from the state hospital system. And perhaps this type of peer review could move outside the state hospital system at some point in the future with legislative change and money. But right now, my sphere of limited influence is the state hospital system. So what you will see coming out of the state hospital system are standardized reports. Standardized with respect to subheadings for ease of peer review. So all competency to stand trial reports that you see out of the state hospital system are going to look substantially the same with respect to the structure of the subheadings. Now, what the individual clinician puts underneath that subheading is their own professional judgment. and will be done based on the person's needs and the need of communication to the court. But the report format is standardized, and it has not been approved yet for mandatory use across the state hospital system. It's making its way through some of the review processes in the committees, and it is being used now to include by the folks at Montgomery County. It's possible that they'll be used by some of the local mental health authorities. But I can tell you what the report looks like. It's going to have opinion on trial competency on the first page. For those of you that don't like to read to the back page, you can just read the front page now. And that opinion on trial competency is going to be yes or no. I mean, how many of you have read a report and you can't tell what the recommendation is, right? So now there'll be an opinion on trial competency, yes or no, on page 1. There will be an opportunity at the end of the report to describe the reason for that opinion. But if you don't want to read the rationale, you can see it up front. You at least know what the report means. The name of the evaluator and their credentials will be on the report. That way you can determine for yourself if they meet those credentials. But it's going to be spelled out. Sources of information will be on every report. What did the evaluator look at? There'll be a statement of non-confidentiality. There'll be a section for pertinent clinical history and information. No more 27-page competency reports. I don't want to write them, you don't want to read them, okay? So clinical history needs to be pertinent in what you as a consumer need to see, not simply a recounting of what someone's hospital course has been. There'll be a mental status exam. How does someone look on the day of that evaluation? And then broken down per Article 46B.024 will be areas of inquiry. 1, to rationally understand the charges and potential consequences of the criminal proceedings. That'll be a subheading area. Then the second subheading will be to disclose to counsel pertinent events and states of mind. The third subheading will be to engage in a reasoned choice of legal strategies and options. These are straight out of statute. 4 will be to understand the adversarial nature of those criminal proceedings. 5 will be to exhibit appropriate courtroom behavior. And 6 will be the ability to testify. Then there'll be a subheading on whether the individual has a severe persistent mental illness or intellectual disability, and if so, what is the impact of that on their capacity to engage with counsel? Then if the defendant is taking psychoactive medications or those medications necessary to maintain competency, and do the medications have any effects on the individual's demeanor or ability to participate in the trial? There'll be an area for diagnostic impression, and then conclusions. That's it. So it'll be subheading driven, we'll subject it to peer review, and I hope that it is easier for you as our consumers. Now, what does programming look like? On the 21st and 22nd of August at Kerrville State Hospital, every state hospital that's engaged in competency restoration was represented, and we established what are the foundational elements of a state-of-the-art competency restoration program. Okay? Competency restoration is more than memorizing facts. In fact, one of the biggest criticisms I hear of restoration programming is that we've simply taught people what to say. But restoration programming is more than simply recitation of facts. And how do hospitals operationalize that? And how do they teach rational thought processes and concepts? So what we've done is we've established an expert panel for competency restoration issues that can be relied upon. Each state hospital has demonstrated that they meet those baseline levels for a medically appropriate restoration program. So if you send a patient to Rio Grande State Hospital or you send a patient to Big Spring, they're going to receive the same baseline level of restoration. Then we'll have a centralized repository of curriculum, training, and best practices that can be utilized across the system. The story I use is that a state hospital had translated a lot of their information into Arabic for one of the persons served, a lot of the restoration information. It was only after that that they realized that the individual didn't read Arabic, only spoke it. But now we've got it. So there's no reason for another facility to do a similar endeavor. We can deposit that centrally and then share resources better across the system. Sanity, again, I'm not going to read to you the law, but what I found in GRI, For a violent offense, individuals come to us for a period not to exceed the maximum period of confinement if convicted, and they're transitioned to the community when no longer dangerous, and then subject to jurisdiction under the court, even as an outpatient. NGRI programming is directed toward their specialized treatment needs with an eye toward community reintegration. If we do something for folks in the state hospital that can't be replicated in the community, then we really haven't helped that person served. So we're looking at ability to take advantage of housing and exploring appropriate housing, what employment might look like, treatment that's transferable to the outpatient side, and substance abuse treatments and interventions given the incredible risk of violence associated with substance use. Should be collaborative with the patient. Psychotherapy is an element, because remember that NGRI equities were unable to distinguish right from wrong at the time of the offense, which could have been months or years ago. How do they reconcile themselves with the fact that they may have committed a horrific act when mentally ill? What does that mean for their life moving forward? Family involvement is important, academic programming, substance use treatment, as I mentioned, teaching job skills. And they're looking at targeted community reintegration and specific reintegration activities necessary for that individual to move out of the hospital and back home in a safe manner. Medications are a huge part of this. Again, I mentioned that medication treatments need to be transferable to other non-hospital settings. So for those of you that run jails, I would very much like for individuals that leave the state hospital to be on a medication regimen that you could administer in jail, and one that is consonant with a formulary in jail. Okay? So that's part of appropriate medication treatment. One of the great things about working in the state hospital as a psychiatrist is that I can use virtually any medication that I want to use. But that's not right for the patient if it can't be replicated elsewhere. And then medication adherence strategies need to be attended to closely, because medication non-adherence is an issue. I mean, how many people in this room took all of their antibiotic the last time they were prescribed an antibiotic, right? So we need to facilitate medication adherence. And before NGRI equities leave our system, they are subject to multiple layers of review. And the first of these is a psychiatric security review done at the facility. And I want to talk a little bit about what that looks like. So we have an NGRI equity in our hospital, and they've stayed for a long time, and the treatment team believes that they're ready to move out. So the treatment team obtains specific forensic consultation from outside of that treatment team. And that outside consultant makes an opinion on whether their violence can be mitigated in less restrictive settings. This is an inquiry into risk to others and community safety. And then that treatment team and that outside evaluator, who still works within the hospital but is not involved in the daily care of that patient, come to a hospital committee composed primarily of department heads, for instance, head of social work, head of psychiatry, head of psychology, and the superintendent of the facility. And community transition is either endorsed by that group, or we say go back and address these issues. So by the time that an NGRI equity is submitted to your court for community transition, they've been subject to peer review already. Then it needs to be collaborative with the local mental health authority. The local mental health authority are the folks tasked with continuing the outpatient care plan, and it needs to be collaborative, and that collaboration needs to start early. The state hospital plan is simply a framework for care that's enacted by the local mental health authority. It would be completely inappropriate for us to tell you how to do your job. Then my hope, ideally, the local mental health authority and the state hospital go to the court hand in hand, present a unified plan to you, the court, that is safe for community and in that person's best interest, and they move forward. Now, what are we changing? We're sharing resources better across the system. No one has enough staff. No one anywhere has enough staff. In fact, I read a study that said 2/3 of small businesses don't have enough staff. So we're attempting to leverage resources across the system to better share expert forensic resources or consultation. In fact, later this week, I'm doing 2 competency evaluations for other facilities by telemedicine. Telemedicine is uniquely suited for forensic assessment. I've been doing it since I was in the military in the late 90s. In fact, it works so well, for those of you in Bexar County, we do telemedicine across the street to the jail because it's easier than getting checked into the jail to do an evaluation. So we're looking at better sharing resources. We've trained folks Because what happened in the state hospital system, and I'm a forensic psychiatrist, this is what I do, it's what I've done for 25 years. But our staff started in a system that was 80% civil and is now almost 70% forensic. And I don't know that the system appropriately supported those clinicians in that forensic transformation. So I've listed out some trainings that have been done across the state hospital system just within the last few months, with an idea that we need to train our folks how to deal with the forensic population. I'm also looking at some pre-admission pilot programs. There's a rural track in West Texas with the West Texas Centers and Big Spring State Hospital, along with other shareholders, and an urban pilot program based in San Antonio, with an idea being that for individuals that are waiting on admission to the state hospital system, are there things that the state hospital system can do to support those individuals while they wait? So for instance, if your jail needs consultation, for an individual on that state hospital waiting list, then it may be appropriate to reach out to the state hospital and say, we've got this person, what do you think we ought to do? Also, if you have somebody that's on the waiting list, waiting in your jail, but taking medications, and has improved significantly clinically, maybe they're competent. And maybe that happened accidentally, because we said that 70% of competency restoration occurs within 6 months of initiation of medications. But the county has already paid for one forensic evaluation. So perhaps the state hospital section can assist the counties in providing that second re-evaluation. I think everybody wins there. The person being served wins. They're diverted from admission to the state hospitals. State hospitals win because we're not putting someone in a bed who doesn't need it. And it's of no additional cost to the county. Sheriff Wilson likes that a lot. So I'll have some data on these pilot programs over the next quarter, but I'm excited about these opportunities. We do have new facilities opening up. I mentioned that at Rusk. There was a groundbreaking last week. There's been a groundbreaking at San Antonio State Hospital. There's new facilities at Ash. There will be additional MSU beds brought online at Kerrville. We're increasing academic linkages. We provide a unique training opportunity for individuals learning about mental health in Texas, and we need to avail ourselves of that to bring them in and teach them what we do, because I'm very proud of the clinical services provided in the state hospitals. Training we've talked about, and I'm interested in jail outreach, both that pre-admission process, that is folks waiting to come to us, and perhaps some post-discharge supports when we send people back to you having already been restored in an inpatient setting. Now, I'm not going to stand between you and lunch, and we've got 3 minutes. What I can tell you is that if you have questions, I'll be here for the next couple of days. Feel free to grab me. I will tell you the truth as I see it. Feel free to email me. I get a lot of emails. If I don't reply back to you, it's not personal. Please just give me a call, and that's my cell phone number. So with 1 minute and 28 seconds to spare, unless there are burning questions that could be answered in now 1 minute and 25 seconds, I appreciate your time.